Neurotrauma is one of those important things that you can never forget. Ultimately, you're trying to be responsible to manage the brain. Okay? Management of the brain is, of course, what your ultimate survival plan is. You can keep the person alive and still be breathing, and if the cortex is gone, you don't have a human being. You just have somebody who's going to be permanently brain damaged. So neurotrauma is one of those sections that you always have to concentrate on the brain, no matter what other injury you have, to protect it. Prior to doing that, you need to understand your anatomy. So again, we've already talked about this, so I'm going to go through this pretty quick. You have to know the different layers. Okay, you have to know the meninges, the dura, the arachnoid, and the pia. Okay, and you have to know how CSF is produced. It's produced as a byproduct of structures inside the ventricles, which is a choroid plexus. The choroid plexus it actually is it's fluid that's kind of plasma-like but different, doesn't have proteins in it, and it goes and produces CSF, which then is reabsorbed via the arachnoid villi in the superior sagittal sinus, okay, which is an interesting circulation pattern that occurs from the ventricle all the way out, going down to the CSF in the spinal cord, all the way back up. The way the CSF actually rotates inside your chest, inside your thoracic cage, is via breathing. So once you impair spontaneous ventilation, CSF circulation slows down, but it still gets propelled by positive pressure, but not as effectively as with the negative inspiration that normally occurs. You have to know the layers, you have to know where CSF production is taking place, and you have to know that there's a blood-brain barrier, which is very important. The blood-brain barrier actually keeps the brain protected from the normal blood toxins, and it's actually a physical membrane that's there. It's actually the astrocytes cover the blood vessel, so it's one more layer thick. So it's a capillary covered by astrocytes that's one cell layer thick, okay, and that protects it and produces this blood-brain barrier. Remember that basically the skull is a fixed structure. The skull basically encases the brain and basically prevents swelling to take place without causing the actual volume to cause herniation through foramens, which are holes inside the skull. So the biggest problem is not so much the pressure, but the intracranial volume changes that occur with swelling and edema that occurs in the brain. Okay? This increase in pressure is dependent on the compliance, which initially you look at the compliance curve. This portion here allows volume to increase initially. Okay? So this portion here allows for the volume to change without causing an increase in pressure. That's your normal ability to absorb injury without any problems. Once you get up into the 2 and 3 range, that's when your pressure rapidly rises, and usually at that point you will begin to herniate around the point 3. What you see is that different people have a different compliance curve. For a person who's young, who's got a very big brain structure inside their skull, the compliance curve is actually here. And somebody who is an alcoholic, who has been drinking for many, many years, will cause a significant drop in their actual their brain mass. Their compliance curve is more flat. Okay? And the reason that's good for them is that they bleed into their head, nothing happens. Versus if you have somebody who's young and healthy, and they bleed into their brain, immediately the compliance changes take place, and the person rapidly herniates. Okay? You see this in young people who get into skiing accidents. They hit their head, they initially wake up, and all of a sudden then they deteriorate very rapidly, and they die. Okay? Versus it was somebody older who fell down and injured, and especially if they were a long-term alcoholic, they're actually walking around with a significant epidural or subdural hematoma without very few symptoms. Okay? So completely different based on the compliance curve. Now, if you increase the volume too much, the brain does herniate. It's not the pressure that herniates, it's actually the volume. Unfortunately, volume is difficult to measure. What's making it more easy to measure is that we're having now intra-ICU CAT scans installed in the big neuro ICU centers. But most ICUs still don't have CAT scans. They're usually at the bottom of the building, very, very far away. It's like listening to a Star Wars drama, galaxy very, very far away. So, usually the transport alone is a miserable event for the people having to take care of these people, and increases the risk of the person herniating in transport. So one of the things that we do is we indirectly then use monitoring via pressures. We used to use a lot of bolts, and they're useless because there's nothing you can do. All you can do is tell you that the pressure's rising, but so what? What can you do about it? Nothing. So instead, what we use now is we do intraventricular drains. We've become a lot more aggressive with that and putting drains directly into the ventricle. So if you do have an increase in pressure, you can temporize by draining some CSF. That doesn't mean that it's not without danger, and they had this event happen about 6 months ago. A nurse didn't understand what an intraventricular drain did, and she dropped the drain on the floor. Okay? Emptied all the CSF out of the person, and guess what happened? Hemorrhaged into their brain, and that was the end of it. So you can't do that either. You cannot empty out the CSF very quickly without causing catastrophic events as well. Okay? So you do have to understand a little bit about CSF drains, including when they get to the OR. Make sure that you know how these things work. Okay? The other thing that you have to understand is perfusion is critical. This was not taught till recently, in the sense that we thought initially that all it was related to was intracranial pressure. If you can control that by actually dropping perfusion, that the patient would get better. But what's really is important about it is that you must maintain perfusion. If you don't maintain perfusion, the brain that's not getting perfused develops edema. So edema is your enemy. So you cannot allow somebody not to be perfused adequately. So cerebral perfusion pressure in the last 10 or 15 years has become much more important than it used to when you listen to the literature, so the literature is still slow to catch up with it. And of course, cerebral perfusion pressure has to do with mean airway pressure, mean arterial pressure minus ICP. This is different than coronary perfusion pressure, which is aortic diastolic pressure, because cerebral vasculature gets perfused through the whole cardiac cycle. So they use the mean arterial pressure as the main pressure in, minus ICP, which is the intracranial pressure, which is inhibiting the blood getting there. Normal cerebral perfusion pressure should be around 90 millimeters of mercury, and ischemia occurs when you get cerebral perfusion pressure less than 50. It seems like the magic number in neurophysiology is 50, so it's kind of nice, you know. I mean, if you ever have to answer something and it says 50, go for it, because 50 tends to be the right answer most of the time, okay? And the other pressure tends to be 150 on the other extreme, okay, which we'll talk about in a minute, okay? So one of the things that you have to do is you have to do the math, and it's not complicated math, so please don't bring a calculator. I'm not going to let you use a calculator for the test, so, you know, just do simple math. If I ask you cerebral perfusion pressure an equation, it's mean arterial pressure minus ICP. It's simple math. 50 minus 10 is 40, okay? So that's hypotension with cerebral ischemia. This is inappropriate mean arterial pressure with elevated ICP. Even though the pressure seems to be adequate, it's not. You're down below ischemic pressures. You're down below 50, okay? So ultimately, how do you actually get blood in there? It's critical to maintain a normal mean arterial pressure. Make sure you're adequately delivering oxygen to the tissues, of course, by delivering enough hemoglobin. Okay? The stroke rate goes up significantly with a hemoglobin of less than 7. That's kind of obvious. I don't care how much oxygen you go in there. If you have no trucks, guess what? It's going to go up. It's really been found recently that the actual critical hemoglobin during cardiopulmonary bypass is 10, not even 9 or 8. So everybody's transfusing to 10 because the risk of developing a stroke goes way down. Okay? So as soon as you get past that barrier number 10, which kind of always made sense, you know, but we had to actually finally have a study that showed that you needed to maintain a hemoglobin greater than 10. The reason that we went to that was because of reactive nature of human beings is HIVs down the road, and nobody wants to give blood, and so instead we try to restrict it back. But in the old days when we were doing heart surgery, everybody was greater than 10. Nobody was allowed to get below 10, and then we allowed it to go down below 10, and sure enough, our stroke rates go up. So guess what? We're back to saying 10's the cutoff for the brain. Okay, so. PaO2 also has to be maintained, usually 75 millimeters of mercury or greater. Don't worry about the kilopascals. I'm not going to ask you that. That's British terminology. CO2 should be around 34 millimeters of mercury. You don't want to vasoconstrict the brain too hard unless you're trying to do it for a reason. And you want to make sure that you maintain your glucose within adequate levels. We know that hyperglycemia increases the brain injury pattern because the glucose is used by the cell to continue to have anaerobic metabolism taking place. And that causes more acidosis in that cell, and it's much more difficult to reverse brain acidosis than it is normal tissue acidosis. It takes like 3 times as longer. So it's not tolerated well. So people that are hyperglycemic die of brain death much more rapidly. Mean arterial pressure, of course, is this equation. I've asked you to memorize that before, so that's something that shouldn't be anything new. Components of mean arterial pressure is not something simple. It's composed of cardiac output, systemic vascular resistance, blood viscosity, the elasticity of the large conducting arteries, and the dynamic pulses, pulsatile flow. The critical part of any exam for when you talk about neurotrauma is this one. You have to know this graph. You have to know the two axes. Specifically, one's in pressure, which is the x-axis, and the y-axis is cerebral blood flow. Please do not say it is cerebral perfusion pressure. It is not. It is cerebral blood flow on the y-axis. Okay? And that is the number of milliliters of blood per 100 grams of brain tissue per minute. Now, do we actually measure cerebral blood flow in the operating room? Absolutely not. Okay, so this is purely theoretical. Okay, but you have to know this theory in your mind so you can actually treat people in the operating room. Okay, now if you use your mean arterial pressure, the pressure between 50 to 150 is the auto system that allows this pressure to stay, the cerebral blood flow to stay constant. So this dark line that you're seeing right here is the mean arterial pressure line. Okay. If you stay between 50 and 150, the person will auto-regulate and not have an issue. Okay? You should maintain adequate cerebral blood flow. If you go above 150, then cerebral blood flow begins to increase and may cause injury. Okay? If you go below 50 in your cerebral perfusion pressure, then you start causing cerebral blood flow to drop off. So it's not what you want to do. Okay? So 50 is a cutoff. The PaO2 is almost the same thing. The PaO2, as long as you're above 60, not an issue. The actual cutoff point, where they say that cerebral blood flow begins to increase, is when you get below 50 on the PaO2, okay, which is on this hash line. You can see once you get above 50 on the PaO2, it doesn't matter anymore. It does not affect vasculature resistance at that point. And the last one that's a linear correlation is CO2, which is this line here. CO2, once you exceed 40, it begins to increase cerebral blood flow. Now notice one thing. What happens at 20? At 20, it goes to 0. So cerebral blood flow goes to 0 at 20 or less. If you're hyperventilating somebody that much, your cerebral blood flow is going to go to 0, and guess what's happening to the brain? It's going to get ischemic. So that's not what you want to do. So usually their cutoff is to 25. If the surgeon is demanding it because he's a neurosurgeon, he tells you, hey, look, I want you to, he's too tight and I got to get in here to get this fixed, you do it as he's asking you to. But try to target around 20 and not get below that. Okay? After 6 hours, what happens to the CO2 response curve? It goes back to normal. So when people tell you, well, I'm going to hyperventilate the guy for about 24 hours and I'm all happy about it, and the answer is you're wasting your time. The first 6 hours it works, but then it auto-regulates back up to its increased cerebral blood flow. So if you were having some effects on cerebral blood flow and you didn't take care of the underlying problem within those 6 hours, then it's going to show up again. Yes? The oxygen line, yep, because then people then don't draw the rest of the line, which is this one. This one means that there's no change in cerebral blood flow. Above 60, about 55 to 60 and on, it doesn't matter at that point. I'm not sure what that fourth line is. The ICP line? Oh, what they're doing is they're showing you the reverse relationship to CO2 to ICP. Okay? What normally happens as you increase your PCO2, okay, when you're up here, your ICP pressure is your highest. Okay? As you get down this way, ICP falls. See, this correlates to this. Yep. It's linear. So it's doing the reverse. Okay? So ICP pressure is its lowest as you hyperventilate. Okay? ICP is basically due to brain volume, CSF volume, and cerebral blood flow volume. Okay? Or cerebral blood volume. Okay? So it's 3 different compartments that you have to deal with. Okay? You have brain tissue, CSF, and blood. The only compartment you can really play with is CSF. You can't really take out brain. If you want to, well, you can. I've seen it done. I've actually seen a hemispherectomy done on somebody that I actually knew pretty well. It was devastating. The patient survived, but was not the same person. Okay? So people can survive without a hemisphere, but they do completely change. Okay? CSF is the easiest thing to draw out, but you got to do it carefully so you don't cause it to drop the pressure to zero. If you drop the pressure to zero, the subarachnoid blood vessels may actually hemorrhage into the ventricles. Now you got subarachnoid hemorrhage with a huge complication. So don't do that. Okay? Control of ICP, you're looking at the different compartments. Look at the volumes. Brain is 84% of the normal volume. 12% is due to CSF, and only 4% is actually blood. Okay? If you increase one, the other ones will have to decrease. Otherwise, the compartment pressure begins to rise. And the normal intracranial pressure is anywhere between 5 to 15. Okay? What can actually increase most ICP is brain edema. Brain edema is your biggest enemy when you're talking about brain injury. What they did with this lady that got shot in the head the other day is they've actually left the skull off. Okay? The reason they left the skull off is to let the edema form underneath the skin, and that way there's ways of controlling the pressure that way. That's a newer treatment now modality. We used to put the skull right back on. And we actually take the skull and then bury it underneath the skin. So you take the skin of the patient, you make it an abdominal pouch, and then you bury the skull in that, and you close it back up. Okay, so that way you can have the actual skull to put it back in that person. Other centers will actually take the skull and then put it and process it, just like they do for a donor. So they'll clean the skull out completely, and that way they'll reuse it at a later time. In combat situations, I've seen a brain, one that was made out of plexiglass, and we actually could look into the guy's brain, and he was still alive. And it was actually very functional. So he'd actually lost most of his skull from a blast injury, and they reconstructed it with a clear plexiglass that you could actually see. The skin wasn't covering it properly, so it was constantly exposed. Eventually, we got a skin graft over it and repaired it. But it was pretty interesting, in the sense that you could actually look at the brain directly and watch it pulsate in somebody who was totally awake talking to you. It was kind of disconcerting. So, but it was kind of ingenious. They actually took a plexiglass piece from a helicopter and cut it and molded it in the field and put it on the guy's head and kept him alive, which was pretty ingenious. Okay? But from that, now we have Kevlar and different things that we actually use, and sometimes we use titanium as well to fill in big holes in the skull. Okay? Somebody had a question? No? Okay. So brain edema is usually your biggest problem. Diuretic therapy is sometimes indicated, it actually works. Intracranial mass lesions, of course, do respond to things like high-dose steroids. And hemorrhage, of course, is a huge complication into the brain. That has very, very bad outcomes because of the ferritin inside the hemoglobin will cause permanent, usually axonal damage taking place inside the brain. So it's not something you ever want to see. You don't want to see free hemorrhaging. Subarachnoid hemorrhaging is much, much worse than a subdural hematoma that causes compression, which can be repaired very quickly. CSF, of course, has decreased absorption, increased production, or obstruction of the drainage can all lead to an increase in CSF mount and then cause problems. And of course, blood, if you exceed the pressure too high and you beat out the autoregulation, then you can get problems as well. Now remember, cerebral blood flow is coupled with cerebral metabolic rate of activity, and that's very important. If you can suppress the cerebral metabolic rate of activity of oxygen consumption, then you drop your cerebral blood flow safely without any problem. So a lot of times what we'll do is we'll take the brain, and just like they're doing to that lady, the congressman, they're giving her high-dose barbiturates and putting her in a coma. Okay? And the coma protects the brain by shutting down the cerebral metabolic rate of oxygen consumption. Okay? That's been used all the way back to the 1920s, believe it or not. Okay, it's gone back. And the other one that actually works very well is hypothermia. So we're actually inducing hypothermia and neurological injuries and actually seeing that we have better survival rates as well. We actually just bought a book if somebody's interested in it. It's in the library talking just about hypothermic resuscitation management. So it's kind of interesting book. Yep. Just for patients that have gone into cardiac arrest in the field. But I think if you're interested in like this kind of area where you're doing a lot of neuroanesthesia, I would recommend you read that book. There's a lot of good basic science in there that will help you understand how the brain acts under under stress and how it swells in different situations. And what you're trying to do is prevent the situation from occurring. So being not reactive, but being, anticipating it and dealing with it early is much more important. Not letting the sugars get elevated on you, driving the cerebral metabolic rate activity down, driving the temperature down to 17 degrees Celsius to shut the brain down are all maneuvers that can be done to save the patient's brain. It's pretty impressive, and it does work. Cerebral blood volume is usually around 60 to 100 cc's in your brain. That's it. That's not a lot. But if anybody's seen a gunshot wound to the head, this doesn't seem right. Okay? Because you've ever seen somebody get a shot in the head, it squirts out at horrendous amounts. It looks at, every time the heart pumps, you're looking at 60 cc's, and about a third of that, so you're looking at 20 to 40 cc's coming out of the brain at one time. And that's a lot of blood ejecting out, and somebody will rapidly exsanguinate. I've seen this also happen from aneurysms that rupture intraoperatively. The patient will hemorrhage so fast that the surgeon won't be able to put a clip on, and the patient exsanguinates on you. Okay? So cerebral blood volume can be altered things like temperature, wakefulness, gravity. Of course, if you put the head up, it drops the blood volume. Blood pressure and carbon dioxide tension. Cerebral blood volume is the total arterial and venous structures in the cranial vault. Most of it is coming from the internal carotid artery, which is 80%, and only 20% is actually coming from the vertebral basilar artery. Cerebral blood flow is, I'm going to stop there, and we'll start back up next week on this. Okay? All right, have a good day, guys.